right, so since I talk at NASA a lot to empty rooms, I'll start my talk. So this talk is on cervical myelopathy. It really serves as an introduction for the rest of the session, because there are some certain things that are pertinent to talk about with regards to myelopathy, even from a basic standpoint. So when we're talking about cervical myelopathy in this session, we're talking about chronic spinal cord compression due to spondylosis as compared to acute spinal cord compression that's seen in the setting of trauma. And so the things that we look for with regards to history and physical examination are really different than they are with an acute spinal cord compression issue. Specifically, the population that we're looking at is people that are typically greater than 50 years old, whose spinal cord compression has come about from spondylosis. And the etiology of why they get dysfunction is an element of debate. It could be simply compression, but it can also be repetitive trauma and a vascular insult due to that repetitive trauma. So again, as an overview, cervical spondylotic myelopathy was described in the 50s, and certainly we've come forward with our understanding of it, principally based on our understanding of imaging studies. The popularity of treatments and interventions for cervical spondylotic myelopathy came after the 70s, particularly with the advancement of MRI and CT scan. So as an overview, we're going to talk about the pathophysiology, the history, and some physical exam findings that we see with it, and talk about this on a more adult level, as we're all surgeons in the room, as compared to normally when I'm teaching this to residents and fellows. So from a pathophysiology standpoint, spondylosis is simply a component of arthritis. Arthritic changes that happen in the disc level, happen in the facet level, ultimately leading to chronic spinal cord compression. With the one caveat which may become pertinent to the later debate and discussion about being cervical spondylosis that would be related to ossification of the posterior longitudinal ligament. In terms of incidence and epidemiology, in looking at a Swiss population, the incidence of males to females is pretty close, 1.4 to 1, if you consider that close. And much like the work that Scott Bowden had put out in previous years, lots of times we see radiographic findings that show cervical spondylosis and cervical spinal cord compression. And I think what will be the pertinent point of Bobby Kalantar's talk will be when do you pull the trigger? When is the proper timing to consider an intervention for cervical spondylotic myelopathy? And that comes to components of findings on their imaging and findings on their physical exam. So OPLL is a more rare condition. It will have some pertinence with regards to our surgical approaches. With regards to the OPLL having a substantial amount of adherence to the anterior dura, making, at least for some, the preferred approach to be posterior if you have the opportunity to try to address their pathology posterior if possible. Again, from a pathophysiology standpoint, which may become pertinent to our laminoplasty debate and is actually one of the arguments against laminoplasty from one of my mentors, who's Ed Benzel, is that some of the spinal cord compression is not just static, it's dynamic. It's probably some of the reason why we see people with central cord injuries. Some argument is that cervical myelopathy may essentially be a microcosm of what we see with central cord injuries, and that perhaps non-fusion techniques, while appealing, may not be the ultimate answer in terms of the treatment of cervical spondylosis with myelopathy. And as I had already alluded to, that there is some argument that there may be a vascular phenomenon involved in this, and this may lead to some discussions in pertinence with regards to maintaining blood pressures before and after surgery. And some pretty animation. So when we talk about some of the components of timing, we have to talk about some of the elicited physical exam findings. And in one of the discussion points amongst the group is that I'm sure if you wanted to convince yourself to operate on somebody with spinal cord compression, finding some of these physical exam findings is a bit subjective. And that's a pertinent point of discussion. So patients who come in with concerns about spinal cord compression have to come with you with two pertinent issues, which is one is they have to have signs of myelopathy and they have to have symptoms of myelopathy. And if they don't, then their interventions of this raise questions as to whether your timing is too early. In addition, like I had stated before, there's numerous studies, particularly those put forth by Scott Bowden, that argue that finding cervical spondylosis is pretty ubiquitous on MRIs as we age. So again, the importance of having a good history to elicit symptoms of cervical spondylosis with myelopathic symptoms is important. So those include, when I describe them to my residents and fellows, is loss of upper extremity dexterity, buttoning buttons, changes in handwriting. Frank weakness tends to be a later finding and also leads to probably a component of what Bobby's going to talk to you about with regards to timing. When we intervene on someone with cervical myelopathy, the argument is to try to intervene at an early enough time that we have meaningful benefit. In other words, if you wait too long, they may not have meaningful benefit because, as you see, patients who become more densely involved with their myelopathy tend to actually have worsened outcomes as compared to those that are intervened on the early side. The other problem is that when is an intervention too early, and that's a likely component of debate. So as we've learned, Lee and Turner had described that the natural history of cervical spondylosis with myelopathy is a stepwise decline. And in addition to their symptoms, we look for physical exam findings. So muscle wasting in the hands, which would be the hand on the right side. This is a finger escape sign. You might recognize the hand. It's mine from an article that I wrote in seminars in spine surgery when I was a fellow. And so the question is which of these is to you enough to, or how many of these is to you enough to decide that an intervention is pertinent? So this is a grip and release finding, which is if the patient cannot do this with 20 repetitions in 1 minute, that's considered a failure. Obviously the Hoffman sign, which is, depending upon whose studies you read, can be positive in normal populations as well, in addition to the myelopathic population. Inverted brachioradialis reflex. And yes, that is my very flat foot. The finding is of a Babinski sign. Spastic large tendon reflexes can be seen for a variety of reasons. I've had the pleasure of diagnosing someone with thyroid cancer in their myelopathic evaluation. It turned out they were hyperthyroid. And obviously clonus. Gait findings, heel-to-toe walking. Heel-to-toe walking winds up being the easiest one to try to elicit a myelopathic finding on a patient, asking somebody who's 80 years old to walk heel-to-toe. Oftentimes, we'll turn to our neurosurgeons of the room, oftentimes has more to do with their cerebellum than it has to do with their myelopathy. And imaging is important. One of the things that's really important about imaging is to consider not just evaluating their MRI findings. So radiographic findings that demonstrate spondylosis may be ubiquitous, but plain films are still important to assess patients' overall cervical range of motion and to particularly assess whether they have maintained cervical lordosis. So MRI findings are particularly important. They tend to be the preponderance of what we look at for spinal cord compression. One of the things that has come to fruition is in looking at those MRI findings is to say, is there any of them that have particular degrees of predictability, such as spinal cord signal changes on the T2, but also on the T1 rated images. So in other words, finding a spinal cord signal change on T2, but also finding a spinal cord signal change on T1 may portend a concern about a patient not having substantial or meaningful improvement, no matter what kind of intervention that we complete. And this is the article that shows the findings that were put forth by Michael Fahling's group on that particular topic. The other thing is that people oftentimes talk about an absolute measurement for the spinal canal. That comes from Scott Bowden's paper with Henry Bowman in terms of the size of the spinal canal being less than 10 millimeters, bearing a concern that they may not see meaningful improvement even if they are decompressed. CT scans are particularly important. They're particularly important to look for osteophytic material. And again, the consideration for a posterior approach as compared to an anterior approach in the setting of ossification of the posterior longitudinal ligament. Grading, there are numerous grading systems, most of which, including this one, which is the neuroclassification system, depend upon physical function. And so the The simplest way, which is when I teach and talk about this, is you can elicit some degree of findings on a patient with regards to their complaints of spinal cord compression, but quality measures such as their ability to walk or their ability to work tend to be ones that weigh more heavily in the evaluation of patients who have meaningful amounts of myelopathy. So our next talk will talk a bit about the timing and considerations for surgery. Frequency and timing of surgery, at least in my hands, involves a patient to have at least one sign and one symptom of myelopathy in addition to the radiographic findings. You'll find that is an element of debate as to where to intervene. The AO and Michael Failings have talked about this a fair amount. And even one of the findings that Michael Failings would argue that you would consider is if you find patients that start to elicit a fair amount of cervical radiculopathy and may not have findings or symptoms of frank cervical myelopathy, that they have a high rate of progression within a few, this is listed as 44 months, a few years of eventually progressing onto that myelopathy. And so considerations for surgical intervention at the most, or in the least careful follow-up, have been advocated. And we'll probably come into the timing discussion of this. And so finally, election as to interventions, to operate or to non-operate. Non-operative treatment when patients are absolutely defined as being myelopathic still remains a consideration if their degree of overall morbidity is so high that a surgical intervention to treat their myelopathy may threaten their life from some other component of their underlying health care. And we talked about, with regards to conservative treatment, what does that really entail? Well, I mean, putting a collar on somebody or giving some motion may be an intervention, but doing nothing in and of itself is a choice as well, and that's something that we choose as surgeons, is sometimes to not treat a pathology. And finally, dating supporting surgery has been really all over the place, and most of the studies that are done support surgery as they're done by surgeons. It really is a question of, as we'll hear about in the next talk, when to intervene. In terms of choosing which surgical approach, what has really come to fruition is that it's all over the place. People elect to do posterior-based surgeries, people elect to do anterior-based surgeries, and a lot of it has to do with surgeon preference, stave a few absolute considerations. Cervical approaches posteriorly have been around a lot longer than cervical approaches anteriorly. But again, patient considerations are most important, and here are a couple of ones that wind up falling into the discussion. Multi-levels tend to have a preponderance to being treated posteriorly, as anterior approaches on multi-levels tend to have higher rates of complications due to dysphagia. Posterior-based approaches tend to have a bias towards people having preserved posterior cervical lordosis. And again, with regards to posterior options, they include posterior patients with a decompressive procedure or posterior decompression and fusion type procedures. Again, the preponderance of patients treated in this manner should have a maintenance of their underlying cervical lordosis. So, again, nothing comes without risk. This is a radiographic example of a post-laminectomy kyphosis. And so again, posterior cervical decompressions and fusions, nothing comes without risks. We're going to hear later about cervical deformity. Unfortunately, as we've heard about with regards to thoracolumbar deformity, a lot of the cervical deformity that we see may or may not be due to us. In other words, being due to iatrogenic considerations of a failure to maintain cervical lordosis at the time of their surgical intervention. Laminoplasty has been an evolution. When I started as a fellow, it was just entering in terms of a discussion point. Heller, from memory, had been a very big proponent of this. And even Henry Bowman, before his death, had been a greater advocate of the use of a laminoplasty procedure, even in the setting of trauma. So again, treatment options, there should be a bias towards the treatment of the pathology for where the pathology is actually occurring. I tend to use anterior-based approaches when there is a lack of cervical lordosis and when there's more anterior-based pathology. And this is just a summary slide showing the different relative advantages one way or the other. So again, having a bias towards the approach being based on the pathology is the underlying theme. This is just the AO data showing the disparity amongst the different types of surgical approaches, with really surgical approaches being all over the place. And there have been numerous articles arguing the effectiveness of anterior versus posterior-based approaches, and I guess that's why we'll be having a debate on some of this components of this later on. So at this point, I would turn this over to Bobby, and we'll go from there.
Thanks, Billy.